Good day everyone, I am Kristine Marquez from BSN Level 3 Section D together with my partner Miss Nichole Centino from BSN Level 3 Section B. So today we are here to discuss to you about a chronic lung condition that, while less common compared to diseases like asthma or chronic obstructive pulmonary disease or the COPD, can have a significant impact on those affected. So this condition is referred to as the bronchiectasis. So imagine this. Our lungs, an essential organ that quietly does its job of bringing oxygen into our bodies and expelling carbon dioxide, are lined with a delicate network of airways called the bronchi. So these bronchi are supposed to remain clear, flexible, and healthy, allowing us to breathe freely. But what happens when these airways become damaged beyond repair? So imagine waking up with a deep, persistent cough, struggling to clear your chest, you're constantly breathless, and lung infections feel like a never-ending battle. Now, imagine living with this every cycle of your life. So, this is the essence and reality of someone with bronchiectasis, a chronic lung condition that we don't hear often, but one that affects thousands of people worldwide. So, this disease, though often underdiagnosed, has been affected more people than we realize. Historically, it was considered a rare condition, but recent data shows that it is far more prevalent than once thought. So, for example, in the United States, the prevalence of bronchiectasis increased significantly over recent years. So, from 139 cases per 100,000 individuals in the year 2000, it rose to 192 cases per 100,000 individuals by the year 2007. So, this increase suggests that while diagnostic methods have improved, the disease remains a substantial health burden. In the United Kingdom, it's estimated that around 485 people are living with this condition, with a staggering prevalence of about 166 per 100,000 in adults over the age of 70. So these figures reveal that bronchiectasis isn't as rare as you once thought. So it is a growing global health concern. Across other parts of the world, the situation is similar. So the growing recognition of bronchiectasis points to the importance of understanding this disease, not only those directly impacted, but are also the healthcare providers and community. So bronchiectasis is a chronic condition that can lead to life-altering symptoms such as a chronic cough, the production of large amount of mucus, frequent lung infections, and breathlessness that can make everyday life or everyday tasks difficult to perform. So this condition may not be a household name, but for those living with it, the condition brings daily challenges that we should all be more aware of. So throughout this discussion, we'll dive into the causes, symptoms, the pathophysiology, and the treatments available for bronchiectasis. But most importantly, we'll shed light on how we can better support and manage this chronic condition that has been flying around the radar for too long. Okay, so now that we have a brief understanding about the condition or about the bronchiectasis, let's dive a little bit deeper into what exactly this condition is. Bronchiectasis is an irreversible chronic lung condition where the air tubes or the tubes going into your lungs widens and are thickened from inflammation and infection. This condition occurs when there is a dilatation of bronchi, especially at the terminal part of the bases of the lungs due to infection. In bronchiectasis, something goes wrong, so wherein these airways become permanently damaged, stretched, and scarred, causing them to widen and lose their ability to properly clear out mucus. So this is a big problem because the accumulation of mucus leads to frequent infections and further damage. So it's a bit like having a blocked pipes in your home. No matter how much water flows through it, the blockage causes a backflow and eventually the system fails to work as it should. So bronchiectasis is a progressive chronic lung condition that starts with damaged airways and leads to lifelong complications. So the damage doesn't reverse, which means it requires a continuous care and management to prevent infections and further deterioration. In fact, most of the common triggers include the severe infections like pneumonia, tuberculosis, or even long-term conditions like cystic fibrosis. To simply put it up, bronchiectasis is a disease of damaged airways. So once these airways become stretched and scarred, they stay that way, leading to a lifetime of respiratory challenges. Now that we know what bronchiectasis is, let's take a closer look at how it develops. So, these are the etiology. First is that the etiology of bronchiectasis is multifactorial and it includes both congenital and acquired causes. And then this condition is a result from recurrent or chronic respiratory infections, particularly bacterial infections, which may damage the bronchial walls and lead to permanent dilatation. Then conditions like cystic fibrosis, which results in thick mucus production and chronic lung infections, are common congenital causes. So, bronchiectasis is unique in that it doesn't have just one single cause. It's a condition with multifactorial etiology, meaning both congenital, present from birth, and acquired causes can lead to its development. So whether you were born with a predisposition or develop it later in life, the end result is the same: damaged airways that struggle to stay clear. So one of the most common genetic conditions linked to bronchiectasis is the cystic fibrosis. So this condition results in the production of thick, sticky mucus that can clog the airways, leading to chronic lung infections and eventually bronchial damage. So these repeated infections are what ultimately cause the permanent widening and scarring of the airways. So other congenital issues includes the primary ciliary dyskinesia, or it is a rare disorder when the cilia, or your tiny hair-like structures that clear mucus from the lungs, don't work properly, which can also result in recurrent infections and airway damage. On the other hand, we also have the acquired causes. So it includes a variety of conditions and environmental factors. For example, chronic respiratory infections are one of the most common culprits. In many parts of the world, particularly in developing countries, untreated or recurrent infections like pneumonia and tuberculosis can significantly damage the airways, leading to bronchiectasis. So this is why in regions with high tuberculosis rates, there is often a higher prevalence of bronchiectasis. Also, in the acquired causes, it includes airway obstructions such as foreign bodies or tumors, chronic inflammatory diseases like COPD and immunodeficiency disorders that predispose individuals to recurrent infection. Okay, so airway obstructions, whether caused by inhaling a foreign object or the presence of a tumor, can also block the airway and trap mucus. So these leads to infection and, over time, permanent dilatation of the bronchi. So an example of this could be the aspiration of a small object in children or the growth of a tumor in older adults, both of which can trigger bronchiectasis. Okay, so another is the chronic inflammatory diseases like the COPD, which causes long-term inflammation and narrowing of the airways, increasing the risk of recurrent infections, which in turn can lead to bronchiectasis. And then additionally, people with immunodeficiency disorders, conditions where the immune system is weakened like HIV or post-organ transplant patients, are at higher risk for recurrent lung infections. This is because their body can't fight off infections as effectively as they were. So this over time can damage the airways, contributing to the development of bronchiectasis. Then lastly, environmental factors such as the exposure to pollutants or irritants can also contribute to its development. So for instance, miners or people working in factories where they are constantly exposed to harmful airborne substances are at a higher risk of developing chronic lung issues, including bronchiectasis. So as you can see, the etiology of bronchiectasis is complex and varied, whether it is due to a genetic factor like the cystic fibrosis or acquired factors such as the repeated lung infections or environmental exposure. So the outcome is still the same: damage to widened airways that struggle to clear mucus, leaving individuals vulnerable to frequent infections and lung complications. Okay, so now that we've explored the causes of bronchiectasis, let's move on to something that is also equally important: the role of infection. So as what we've learned, repeated lung infections are not only a cause of the condition, but it is also a major factor in worsening the condition. So these infections are caused by various pathogens, such as bacteria, fungi, or even viruses that colonize the damaged airways, making it harder for the body to fight them off. So the two most common bacterial culprits behind these infections are Haemophilus influenzae and the Pseudomonas aeruginosa. So first on the list is the Haemophilus influenzae. Despite what its name might suggest, the bacterium is not related to the flu virus, but it is a significant cause of respiratory infections. In patients with bronchiectasis, Haemophilus influenza is frequently detected and is known to cause persistent or recurrent infections. It can thrive in the widened and scarred airways where mucus builds up, creating the perfect environment for the bacteria to multiply. So what makes the Haemophilus influenza particularly problematic is its ability to form biofilms. So when we say biofilms, these are slimy layers that allows bacteria to stick to the airways and resist antibiotics. So this makes it difficult to completely clear the infection, leading to chronic inflammation and further damage of the lungs. Next, we have the Pseudomonas aeruginosa. It is a more aggressive and dangerous pathogen. So unlike the first one, this pathogen is typically found in more severe cases of bronchiectasis. So the Pseudomonas aeruginosa is especially worrisome because it tends to infect people with weakened immune systems or those with already damaged lung tissue. So one of the reasons why the Pseudomonas aeruginosa is so problematic is that its resistance to multiple antibiotics, making it hard to treat. So it can also form biofilms, much like Haemophilus influenza, allowing it to stick to the airway surfaces and persist despite aggressive treatment. So when a patient is colonized by Pseudomonas, their symptoms can significantly worsen, leading to more frequent exacerbations or flare-ups and faster lung infection decline. Patients with Pseudomonas infections often experience increased sputum production, more severe coughing, and greater breathing difficulty compared to those infected with other bacteria. So other pathogen, though less common, can also be involved in bronchiectasis. This include the Staphylococcus aureus, Moraxella catarrhalis, and even non-tuberculosis myobacteria or the NTM. However, the Haemophilus influenza and Pseudomonas aeruginosa remains as the primary pathogens that bronchiectasis patients must contend with. Okay, so now that we understand the pathogens and the causes, let's dive into the various forms of bronchiectasis: the cylindrical, varicose, and saccular or cystic bronchiectasis. So let's begin with the most common form, which is the cylindrical bronchiectasis. So it is the most common form, characterized by uniformly dilated airways resembling cylinders. Clinically, this form tends to be milder than other types, with fewer flare-ups of infection. However, over time, even cylindrical bronchiectasis can lead to chronic respiratory issues if left unmanaged. The next form is the varicose bronchiectasis. So in this type, the airway appears to be twisted and dilated, similar to varicose veins. So in this type of bronchiectasis, the airways become irregularly dilated, alternating between wide and narrow sections, much like the appearance of twisted vines. So the constant shifting in airway size makes it harder for mucus to move out, which leads to more frequent infections and worsening lung damage. So you can think of this form as more advanced than the cylindrical type, with greater structural changes. So the last form is the saccular or cystic bronchiectasis. So this form is characterized by the presence of large balloon-like sacs at the ends of the bronchi. So we have the most severe form, which is the saccular or cystic bronchiectasis. So in this form, the airways are massively dilated and form a large balloon-like sacs at their ends, often described as resembling grape clusters. So these large spaces can trap even more mucus, making it extremely difficult for the lungs to clear out debris and bacteria. So as a result, patients with this type of bronchiectasis tends to have more severe symptoms, including chronic cough, frequent infections, and significant lung function decline. So this form is more likely to be seen in people with long-term untreated disease or with underlying conditions like cystic fibrosis. Okay, so now let's move on to the key signs and symptoms that help us recognize this condition. So bronchiectasis doesn't just affect the lungs in one way. It presents a variety of symptoms that can deeply impact a person's daily life. So let's go over some of the most common symptoms and reasons why they occur. So first in the list is daily cough and production of mucus or sputum. So for someone with this condition, coughing isn't just an occasional event. It's something they experience almost every day. So this chronic cough is the body's way of trying to clear out the excess mucus trapped in the airways. So the pathognomonic sign of bronchiectasis is the persistent production of large amount of purulent sputum. When we say purulent, it means a pus-filled. So pus-filled sputum. So particularly after a chronic cough. So this occurs due to the permanent dilatation of the bronchi, which leads to mucus buildup and frequent infections, making the symptom a key distinguishing feature of the condition. Next in the list of signs and symptoms is the shortness of breath. So when the airways are damaged, the lungs can't function as effectively. So this is because the extra mucus and inflammation narrow the airways, reducing the amount of oxygen that can enter the lungs and making it harder to breathe. So over time, lung function declines, leading to a feeling of breathlessness, especially during activities like walking or climbing stairs. Okay, so next is fatigue and feeling run down or tired is another common symptom. So living with chronic lung disease takes a toll on the body. So the constant coughing, the effort to breathe, and the frequent infections can leave someone feeling exhausted. So the body is in a constant state of fighting off infections and trying to maintain adequate oxygen levels, which drain energies. Then we have also the fevers or chills that often accompany bronchiectasis, particularly during flare-ups or exacerbations. So these are signs that the body is battling an infection, which is common in individuals with this condition. Then we also have wheezing. So wheezing is another sign that can be present. It is the whistling sound you hear when someone breathes, and it happens because of the narrowing of the airways. So in bronchiectasis, the airways are not only widened but can also become inflamed, swollen, or blocked with mucus. So this obstruction leads to difficulty in air movement, causing the distinctive wheezing sound during breathing. Then we also have the hemoptysis, or the coughing up of the blood, or coughing up blood. So this can occur in more advanced cases of bronchiectasis. The damaged and fragile bronchial walls can easily bleed, particularly when they're inflamed or infected. So this bleeding often presents as streaks of blood in the sputum, but in more severe cases, large amounts of blood can be coughed up. Lastly, let's talk about clubbing, which is the last sign and symptom. So it refers to the rounding and swelling of the fingertips and toes. So this is a result of chronic low oxygen levels in the body, which can happen in people with long-standing lung disease. So clubbing occurs because the body, deprived of enough oxygen, triggers changes in the structure of the nails and the fingers. So it's a sign that lungs are not able to deliver enough oxygen to the body over time, which further indicates the severity of lung damage. Okay, so let's now discuss the pathophysiology of bronchiectasis, starting from the non-modifiable factors. So first on the list is the genetic predisposition. So this refers to the inherited genetic factors that increase a person's likelihood of developing the condition or particular condition. So conditions such as cystic fibrosis and primary ciliary dyskinesia fall into this category. Then second on the list is age. It is considered as a non-modifiable factor because it naturally progresses, and its impact on bronchiectasis is due to the cumulative exposure to risk factors over a person's lifetime. Okay, so third on the list is the congenital anomalies. So the congenital anomalies are structural defects in the lungs or respiratory system present at birth. So then the fourth on the list is the previous infections. So severe respiratory infections in childhood such as pneumonia or whooping cough can cause significant lung damage that persists in adulthood. So these infections can lead to chronic inflammation and scarring of the airways, which impairs lung function and predisposes individuals to bronchiectasis. Okay, so fifth on our list is immunodeficiencies. So these are conditions where the immune system is weakened or absent, making individuals more susceptible to infection. So in bronchiectasis, both primary and secondary immunodeficiencies can lead to recurrent lung infections. Okay, so last in the list on our non-modifiable factors are the autoimmune diseases, such as the rheumatoid arthritis or systemic lupus erythematosus. So this occur when the body's immune system mistakenly attacks its own tissues. So in the lungs, this can lead to chronic inflammation, tissue damage, and the development of bronchiectasis. So the autoimmune process is driven by a person's immune system and genetics, making these diseases non-modifiable. Okay, so let's now proceed to the modifiable factors of bronchiectasis. First on the list is smoking, which is one of the most significant modifiable factors for bronchiectasis. So the harmful chemical in cigarette smoke causes inflammation and damage to the lung tissues, impairing the airway's ability to clear mucus effectively. So this can cause the recurrent infections and chronic bronchial inflammation, contributing to bronchiectasis. Okay, so second on the list is the recurrent respiratory infections. So examples of these infections include the pneumonia, tuberculosis, or severe viral infection that damages the bronchial walls and impair the lungs' natural defense mechanism. So frequent infections cause chronic inflammation and scarring, leading to bronchial dilatation and mucus retention, which are the key characteristics of bronchiectasis. Okay, so third on our list are the air pollution and exposure to lung irritants. So air pollution and exposure to irritants like chemicals, dust, fumes, and occupational hazards, for example, working in mines or in factories, can irritate the airways and lead to chronic inflammation. So these environmental factors can contribute to bronchial damage and mucus buildup, increasing the risk of bronchiectasis over time. Fourth on our list is the chronic condition management. So poor management of chronic conditions such as asthma, COPD, GERD can contribute to bronchiectasis. So inadequately controlled asthma or COPD can cause frequent exacerbation and inflammation of the airways, leading to bronchial dilation. So GERD can also result in recurrent aspiration, which can irritate and damage the airways. Proper management of these conditions with medication, lifestyle changes, and regular medical follow-up can reduce complications and lower risk of bronchiectasis progressions. Okay, so last on our list is poor airway clearance. So it refers to the inadequate removal of mucus from the lungs, which can lead to mucus accumulation, recurrent infections, and inflammation, all of which can contribute to bronchiectasis. So this can be caused by conditions like, again, primary ciliary dyskinesia, but it is also modifiable through techniques like chest physiotherapy, postural damage, and the use of devices that can help clear mucus. Okay, let's proceed with the discussion of the initial insult of the bronchiectasis. So when we say initial insult, it refers to the underlying event or condition that triggers the cascade of damage and inflammation in the airways, ultimately leading to the development of bronchiectasis. So in most cases, bronchiectasis develops due to repeated or chronic injury to the bronchial wall. So the initial insult can be an infection, exposure to toxins, or a defect in the body's immune system or airway structure. So these insults cause chronic inflammation, impair the normal clearance of mucus, and lead to dilatation and destruction of the bronchial wall. So there are at least 5 key features of bronchiectasis. First is the acquired immunodeficiency. It refers to a weakened immune system that develops later in life, typically due to conditions like HIV or the use of immunosuppressive drugs such as after organ transplants or in cancer therapy. So a compromised immune system leads to an increased susceptibility to respiratory infections because the body is less capable of fighting pathogens. So these recurrent or severe infections can be initial insult that cause chronic inflammation in the airways, resulting in damage to the bronchial walls and mucous retention. So the next key feature of the bronchiectasis is the autoimmune diseases. So autoimmune diseases such as the rheumatoid arthritis or systemic lupus erythematosus, the body's immune system mistakenly attacks its own tissue, including the lungs. So the immune system's attack leads to chronic inflammation in the bronchial walls, which can act as the initial insult, damaging the airway. So this inflammation results in the destruction of airway tissues, loss of elasticity, and impaired mucus clearance, all of which contribute to the development of bronchiectasis. Next on our list is the congenital or genetic factors, which refers to the condition present from birth that predispose individuals to bronchiectasis or as well as specific conditions. So examples include cystic fibrosis and primary ciliary dyskinesia. Then we also have the endotracheal obstruction, which refers to the blockages in the airway, either due to the foreign objects, tumors, or restrictures, or the narrowing of the airway. So when the airway is obstructed, mucus clearance is impaired, creating an environment conducive to infection and inflammation. The last key feature of bronchiectasis is the inhalation exposure, which refers to the exposure to harmful substances such as smoke, chemicals, toxic gas, or environmental pollutants, which can directly irritate the bronchial lining and lead to infection. So continuous exposure to these irritants damages the airway epithelium and impairs the body's natural defense mechanisms. So this serves as the initial insult by initiating chronic inflammation and making the airways more susceptible to infection. Okay, so bronchiectasis is characterized by persistent damage to the lungs due to ongoing infections, inflammation, and structural changes in the airway. So this damage leads to impaired lung function and chronic respiratory symptoms. So let's talk about the specific aspects of this damage. The first is the irreversibly dilated bronchi. So in bronchiectasis, irreversibly dilated bronchi are a defining feature. Normally, the bronchi maintain their structure and tone due to the presence of elastic tissue and smooth muscle. However, chronic inflammation and repeated infections weaken the walls of the bronchi, leading to their permanent dilation. This structural change disrupts their normal airflow and impairs the lungs' ability to clear mucus, making it easier for bacteria to colonize the airway. So over time, this dilated bronchi trap mucus, leading to repeated infections and further lung damage. So once this dilation occurs, the bronchi cannot return into their normal size, making this damage irreversible. Okay, so the next aspect of this damage is the chronic bronchial infection and inflammation. So these are the central aspect to the ongoing lung damage in bronchiectasis. So the dilated bronchi are prone to mucus buildup, which creates a favorable environment for infection. So when bacteria, viruses, or fungi colonize the airways, they trigger an immune response, causing the release of inflammatory cells and chemicals such as cytokines to fight the infection. However, this chronic inflammatory response damages the bronchial walls even further. So as the inflammation continues, the bronchial walls become thicker, scarred, and less able to clear infection. So this creates a cycle where the chronic infections lead to more inflammation, which leads to further structural damage, impairing lung function over time. And then lastly, easily collapsed airway. So in bronchiectasis, the airways become easily collapsed due to structural weakening and damage to supporting tissues. Normally, the bronchi have elastic fibers and smooth muscles that help them maintain their shape during breathing. However, repeated inflammation and infection can cause the loss of elasticity in the bronchial walls. So as a result, the airways become more prone to collapse, especially during inhalation when the pressure in the chest increases. So this airway collapse leads to air trapping and difficulties in fully expelling air from the lungs, which contributes to symptoms like wheezing, breathlessness, and chronic coughing. So easily collapsed airways also further impair mucus clearance, which exacerbates the cycle of infection and inflammation, worsening the progression of bronchiectasis. Okay, so bronchiectasis is characterized by persistent and progressive damage to the lungs, leading to a variety of symptoms and complications. So, central to the pathophysiology of bronchiectasis is the presence of persistent bacteria in the airway. So, a defect in immunity and or mucus clearance plays a crucial role in the development of the condition. So, this can be due to various factors, including genetic predispositions, underlying diseases, or exposure to irritants. Okay, so when the body's ability to fight off infections and clear mucus is compromised, it causes or it creates a perfect environment conducive to bacterial growth and lung damage. This also often involves pathogens like as the Pseudomonas aeruginosa and Haemophilus influenza, as well as the other pathogens. Then the chronic presence of this bacteria triggers an inflammatory response, leading to tissue damage, epithelial destruction of the airways, and further impairment of bacterial clearance. So the consequences of these factors leads to chronic cough, which is the hallmark symptom of bronchiectasis, often producing mucopurulent sputum due to the presence of bacteria and inflammation. The rhinosinusitis or the inflammation in the lungs that can extend to the sinuses, causing nasal congestion, sinus pain, and drainage. Then fever, which is a common symptom of infection, which is often present in bronchiectasis due to the persistent bacterial colonization. Then also the persistent inspiratory adventitious sounds such as crackles and wheezings are indicative of lung infection and fluid buildup. Then we also have the digital clubbing. This is a physical sign where the fingertips become enlarged and bulbous, often seen in patients with chronic lung conditions like bronchiectasis. Then lastly, the VQ mismatch. This refers to a mismatch between the ventilation or the amount of air reaching the lungs and and the perfusion, which is the amount of blood flowing to the lungs, which can occur in bronchiectasis due to the damage of the airways and vessels.
Bronchiectasis is a lung condition where the airways or the bronchi becomes abnormally widened, which damages the cilia or the hair-like structure that helps clear mucus. This damage makes it hard for mucus to move out of the lungs, and since mucus cannot move out from the lungs easily, it causes buildup. Then that buildup becomes a favorable environment for a bacteria to grow, which leads to recurrent infection. Then this infection, over time, weakens the immune response in the airways and further causes impaired mucus clearance and worsening lung function. Now, in children, the defective immune system makes them prone to lung infection. Now, this infection makes their body to have difficulty getting enough oxygen, which makes the child feel tired and weak. Now, this increases the body's demand in energy. However, as the energy demand increases, the appetite also decreases, leading to poor nutrition. Together, this causes failure to thrive or the child does not gain weight or grow as expected. Also, the defect of immune system activates inflammation to fight infection. While the inflammation is meant to help, if it happens too long or too often, it damages the lung tissues. It is because the immune cells releases enzymes and chemicals that tries to kill the bacteria, which causes the infection. However, in their effort to kill the infection, they also break down healthy tissues, which now leads to the structural damage of bronchial walls. It is because the tissue damage weakens and breaks down the bronchial walls, causing scarring, loss of elasticity, and thickening. Over time, this leads to airway dilation, making them less able to clear mucus and more prone to further damage, resulting in permanent structural damage. Now, this structural damage of bronchial walls narrows airways, making it harder for air to flow smoothly, which results to whistling sounds like wheezing when you breathe in. Tissue damage can also cause epithelial destruction of airways, as tissue damage also destroys the airway's protective lining or the epithelium, making it harder to clear the bacteria. Now, when the epithelium is damaged, this also causes the blood vessels to become more fragile and susceptible to rupture, leading to bleeding and the presence of blood in the mucus or coughing of blood, or also known as the hemoptysis. The combination of coughing can create further discomfort, resulting to chest pain. When the lining of the airway or the epithelium gets damaged, it can't protect or clear out bacteria as well. The cilia, which moves mucus and germs out of the lungs, stops working properly, so mucus builds up and the bacteria can grow more, which leads to further impairment of bacterial clearance. This damage also causes swelling and narrowing of the airways, making it harder to breathe, leading to sounds like crackles or wheezing during breathing. Epithelial destruction of airways also leads to ventilation perfusion mismatch and decreased gas oxygen. It is because when the epithelial cells in the airways are damaged, it can lead to swelling and blockage of the airway. This prevents air from reaching parts of the lungs properly, reducing ventilation. However, since the blood is still flowing, there is an imbalanced supply between air and blood supply. As a result, less oxygen gets into the blood and less carbon dioxide is removed. This leads to decreased overall oxygen level of the body. Now, this decreased oxygenation leads to digital clogging, which is rare, fatigue, dyspnea, and cyanosis, which is also uncommon. And now let us proceed to the assessment and the diagnostic findings. So first, we have the high-resolution computed tomography, or the HRCT. So it is the most sensitive and specific non-invasive method for diagnosing bronchiectasis. Then we have also the chest X-ray, which is less sensitive than HRCT. Chest X-rays may show bronchial wall thickening, hyperinflation, and areas of atelectasis and or fibrosis. Then we also have the pulmonary function tests, or the PFTs, which reveal an obstructive pattern with reduced FEV1 and FBC ratios, although some patients may also have restrictive pattern in advanced diseases. So what is this FEV1 and FBC? So FEV1, or the forced expiratory volume in 1 second, measures how much air you can exhale in 1 second, while the FBC, or the forced volume capacity, measures the total volume amount of air you can exhale forcefully in one breath. Then we also have the sputum culture, or the sputum analysis, which reveal common pathogens such as Pseudomonas aeruginosa, Haemophilus influenzae, and Staphylococcus aureus, which are often responsible for recurrent infections. Then the bronchoscopy, which in some cases, bronchoscopy may be performed to rule out other causes like foreign body aspiration and to obtain samples for microbiological analysis. Then the blood test, inflammatory markers like C-reactive protein, or the CRP, and white blood cell counts may be elevated during acute exacerbations. Tests for immunoglobulin levels may be used to rule out underlying immune deficiencies. Then lastly, we have the sweat chloride test, or the genetic testing. For patients suspected of having cystic fibrosis-related bronchiectasis, these tests can help confirm the diagnosis of CF. For the medical management, we have the hydration. Adequate hydration is encouraged to keep secretions loose and easy to expectorate. Then surgical intervention. In cases where localized bronchiectasis does not respond to medical management, surgical restrictions may be considered. This is usually reserved for patients with significant hemoptysis or recurrent infections. Then Lastly is the pulmonary rehabilitation. A program of exercises and education may be prescribed to help improve the patient's overall physical conditioning and reduce symptoms like dyspnea. For the nursing management, first is to teach and assist patients with technique to promote effective airway clearance. This includes chest physiotherapy and postural drainage. The nurse should assess and address nutritional needs, ensure the proper administration of prescribed medications. Teaching patients about self-care techniques is also vital, like educating them on recognizing early signs of infection or exacerbation, importance of adherence to medications, and strategies to prevent respiratory infections like proper hand hygiene and vaccinations. The regular monitoring of respiratory status, including lung sounds, oxygen saturation, and signs of infection, allows prompt intervention if patient's condition gets worsened. Then assist by facilitating access to counseling or support groups and encouraging adherence to pulmonary rehabilitation programs, which can help improve overall quality of life. For the prevention, first is prompt treatment of respiratory infections, vaccination, avoidance of environmental irritants, managing underlying conditions such as cystic fibrosis, chronic obstructive pulmonary disease, or immune system deficiencies, good respiratory hygiene, and pulmonary rehabilitation. The prognosis of the bronchiectasis largely depends on the extent of airway damage, the control of recurrent infections, and the management of underlying conditions. According to Hinkle and Cheever, early detection and treatment of infections, along with proper management of conditions such as cystic fibrosis or chronic obstructive pulmonary disease, can significantly improve outcomes. However, in severe cases where the bronchial walls are extensively damaged, patients may experience a progressive decline in a lung function and frequent exacerbations. Long-term prognosis varies, but with effective treatment, many individuals can maintain stable lung function and a good quality of life.